Good morning. This is Dr. Howard Haft, and I'm pleased to be here with you today in absentia. I very much wish I could be with you in person, but called away to another important meeting out of the state. Today we'll go through some basic things, and I'd like to really tell you about at least two issues related to the Maryland Primary Care Program. One is, most importantly, the reason why we have a Maryland Primary Care Program, and the second is going to be some details about the program itself. So here's a picture of me. You can wipe that picture out of your mind if you'd like, and let's proceed with the presentation. First of all, I have no disclosures related to this presentation. Second, the training design is that this particular program is really focused on practice staff. It's different from a program that will be presented later in the year and through the next year that's focused on the providers in the MD-PCP practices. There may be some providers in the audience. If there are, please note that, again, most of the material here is focused on the staff level. You're welcome to stay and welcome to ask questions and contribute, but there will be some additional trainings later in the year, specifically for providers in the program. There's a pre-survey. I would appreciate if you take a few moments now and fill out that pre-survey, and then we'll move on with the presentation. Most importantly, I want to tell you today about why we are doing the Maryland Primary Care Program. And there's several big reasons why that is. One is overall to provide the best quality health for all Marylanders. And I know that's what you all do every day in your practices. And this is meant to enhance your ability to do that. The second, importantly, is to shift our entire system within the state from the ever-increasing demands of volume, increasing the number of people you see every day, and having that number being seen in a shorter and shorter period, to seeing people more for the needs that they have and spending more time with patients who have greater needs, and taking care of those patients who have lesser needs in other innovative ways. Specifically in this program, we also want to make sure that we're avoiding unnecessary hospital and emergency department visits. This doesn't mean that people who need to go to our great hospitals or to our emergency rooms for true emergencies shouldn't do that, but many, many things can be taken care of in the primary care offices. Things that require more access or more abilities within the primary care offices or more resources. We want to make sure that within this program that we're providing all of those resources so that you can make sure that your patients don't unnecessarily need to go to the emergency department or have to be admitted to the hospital for things that ordinarily would be taken care of in the primary care world. And most of all, we want to show Maryland off as a really great example of how healthcare can be delivered in the best way for all the citizens of Maryland. I'd like to spend a minute now and have you see a short video that really gets to the reason of the importance of why we do things.
So you're a musical director?
Yes,
Cool.
sir.
All right, so let me get a couple bars of like Amazing Grace. Can you do the first part of that? Go ahead.
Amazing grace, how sweet the sound that saved a wretch like me.
Wow. That bro could sing. You know what I'm saying? All right. Now, what you give me the version is if your uncle just got out of jail, you got shot in the back when you was a kid. I'm just saying, let me see the hood version real quick if you know which version I'm talking about. Just see if that exists. Let me see what you got.
Amazing grace, how sweet the sound that saved a wretch like me.
So here's the thing. The first time I asked him to sing, he knew what he was doing. The second time I asked him to sing, he knew why he was doing it. When you know your why, your what has more impact because you're walking in or towards your purpose.
So this is to point out the fact that when you know why you're doing something, your passion and your engagement are so much more intense. And I'd like to spend a few minutes and tell you a little bit more about the why behind the Maryland Primary Care Program. And I'd like to start with this very iconic picture. This is actually a picture that Norman Rockwell painted as part of a series that he did for the Saturday Evening Post. And this one appeared in 1948, in June of 1948. And it's actually a picture of Norman and his family being taken care of by Dr. Russell, who was their family doctor in Arlington, Vermont. And Norman felt so strongly about Dr. Russell and how he delivered care that he actually wrote a piece for the Saturday Evening Post. And in it, I'll paraphrase, he said that Dr. Russell was so important to the town that he took care of not only our medical needs, but all of the needs of everyone in the community that he served. And he was truly indispensable. And this is a picture at a time, not so many years ago, when the healthcare costs were about $100 per capita. That is, every man, woman, and child in the country spent on the average about $100 on their healthcare, and people lived to the ripe old age of 67 or 68. So we've made some advances since then, but I think as you'll see in the subsequent slides, we've also created some challenges. So here's one of the challenges, is that we all think about the United States and our healthcare system as being absolutely the greatest in the world, because people come from all over the world to come here to our great institutions, and Johns Hopkins and University of Maryland, and even to the Peninsula Regional General and other places, because we think about this as being just the greatest place to get healthcare in the world. But when we're objectively ranked by the World Health Organization, we find that we're not the best. We're actually the 39th best in the world, which makes you think, why is that? If we think we're the best, what are we doing wrong, and what can we do better? So here's one of the clues to that. This is another slide that shows you what the relative wealth of countries are, economically developed countries around the world, and correspondingly what the relative amount that they spend in healthcare. And you can see the US stands out there brightly at the top of the scale in terms of how much we spend on healthcare. It's a fairly rich country. It's maybe third or fourth richest in the world, after places like Luxembourg and Ireland and Switzerland. But comparatively, we spend far more than any other economically developed country in the globe does on healthcare. We're spending more than $10,000 per person per year on healthcare in this country. That now, in comparison to the Norman Rockwell picture, $100 and $10,000 is quite an enormous gap. But even twice as much as any other economically developed country, we should have a strong expectation of what we get for that. That amount amounts to $3.5 trillion a year, and occupies almost 20% of all the gross domestic product. That's of all the money that's spent for anything, goods and services in the country. $1 out of every 5 goes to healthcare. So that's good if you're in the healthcare industry, but if you're receiving healthcare, you want to get something for that. So what do we get for that? Let's look at this next slide, and we find one of the things that we hope to get is that we can, on the average, live longer in this country than other countries comparatively who spend less money. But we find that's not actually the case. We can see the light blue bar in the middle of this slide is the average life expectancy of economically developed countries. It's 82 years. Some countries have far more than that, as we find Japan and Switzerland and Australia. And the US is actually down on the bottom of that rank. And we find that we actually are not getting more longevity, more life expectancy out of the investment we're making in healthcare, which is a problem. And even more problematic, over the last 2 years, our life expectancy in this country is declining. After more than 75 years of increases every year, year over year increases in life expectancy, much of it due to public health interventions, we find now that our life expectancies are decreasing, which is not a good figure. So we also look at the disease burden, and this is kind of I would say, a wonky way of looking at that. It's what we call DALYs, or disability adjusted life years. And it's a combination of the disease burden that people have and unexpected or intervenable shortening of their life. And it's a number that we'd want to see smaller than other countries. But here, paradoxically, we're almost twice what the average is for economically developed countries. So we have much more disability and disease burden in the US. And again, this is despite spending a lot of money. Here's one of the clues to why we might be experiencing this kind of cognitive dissonance about thinking about us being the best, but not really having the numbers to prove it. When we look at the number of primary care providers we have compared to specialists, and then look at how we compare it to other countries, we have about 12% of all of our providers are primary care, 88% are specialists or other areas. In other economically developed countries that do much, much better, like Canada and the UK and France, in terms of lower costs and higher quality, have far more percentage-wise numbers of primary care providers. So that's kind of a clue to why we might not be doing as well as we think, and also a clue to why the MD-PCP, the Maryland Primary Care Program, is so important to us. So with this clue in mind, and with other pressing issues, the state of Maryland signed on July 9th of 2018, the Total Cost of Care Model Contract Agreement, and signed by this august group of people that you can see here: the governor, the head of the Senate and the House, and dignitaries from the federal government and others, all of who said, we need to do something different here in Maryland. And the something different that we did was this total cost of care model contract. And it has many pieces to it, but you can see all the pieces are focused on patient-centered care. It has a big piece that the hospitals contribute with population-based revenue, where hospitals have agreed to reduce over the next 5 years by a significant amount of money the total cost of care for Medicare, Part A and Part B, both ambulatory and inpatient. And they're doing many, many things to do that. There's a care redesign program that allows hospitals to work with many different providers across the state in innovative ways to reduce the cost of care and improve the quality. There's also a big piece where the state has said, we are committed to reducing some of the disease burdens in the state, and we've picked diabetes as the first one of those, and committed to reducing the incidence of diabetes year over year in Maryland compared to how other states are doing. And we'll get back some credits against our total cost of care for doing that. But at the bottom, in the center of this, is the Maryland Primary Care Program. That's your program, the program that you're involved in, and that's really intended to improve the health of Marylanders, to provide more access to the great primary care programs that we have that are in this Maryland Primary Care program practice, and to give them more resources, and to particularly focus on the important things in their health and help manage their care, particularly for those who are sickest, and keep them out of unnecessarily going to the hospital and the emergency department. So we're making big investments in doing this, and let's talk a little bit more about what's inside of that Maryland Primary Care Program, and then we'll talk a little bit about the supports that you'll get as being part of the Maryland Primary Care Program. So again, why primary care? So we showed you a little bit in the past slides about international experience, but there's some evidence right here in the United States from other states that, and from some recent articles, that primary care really is a solution to this high cost and low quality problem that we have. We've also heard loud and clear through the development of the total cost of care model contract from our stakeholders that whatever you do in this contract, make sure you have a strong place for primary care. And primary care are our single largest group of providers in the state. And more than that, even though they're the single largest group of providers, we only spend 5% of the total healthcare cost spend in the whole state in primary care, suggesting that by making more investments in primary care, we might be able to actually do better in terms of quality and outcomes. And it's the best place to avoid unnecessary hospital and emergency department visits. And last on this list, but not to be neglected, is that primary care over the last several years has experienced a lot of provider and staff burnout because we've been calling on them to do much more with much less, seeing more and more patients with fewer and fewer resources. And this is a way to offset that burnout, to help invest in primary care and elevate primary care in terms of importance in the delivery system. So there's been some recent US experience, particularly in Rhode Island and now in a few other states, but I highlight this article that was in Health Affairs this very year in February, where the state of Rhode Island put together a program where they said we are going to be very purposeful in increasing the amount that we spend in primary care year over year. And once they did that, they saw very interestingly a decrease in the total cost of care for that state for spending, and correspondingly an increase in quality and outcomes. So that was really a great bit of evidence about how making investments in primary care in a statewide system can produce better outcomes. There's also a very interesting study that appeared in the Journal of the American Medical Association, one of the oldest and most revered journals in the world. And this was an experimental model where the scientists said, what happens if we increase in a population of 100,000 individuals by 10 the number of primary care providers in that population? What happens to the life expectancy of that population? And they found that if you do that, you can expect that the life expectancy for that population will increase by 50 days in a year. So that's in contrast to what we said before in the earlier part of this presentation, that we're seeing a decrease nationally in life expectancy. So put those two things together. Again, this is not the real life, this is an experimental model, but when you use this very solid experimental model and put it together, you can say maybe by increasing primary care numbers in a particular area, that we can actually improve the longevity for that area. This is a particularly notable issue for places like the Eastern Shore where there's a shortage of primary care doctors. So now we're going to talk a little bit about the requirements for the overall primary care program and just highlight some of the things that you're going to hear more about during the rest of the day. So there are 5 advanced primary care functions that you'll see and hear about within the program: access and continuity, care management, comprehensiveness and coordination, beneficiary caregiver experience, and planned care for health outcomes. And I'll talk about each of those now in a very high level, just so you can understand what we're shooting for in each of these elements. First, with access and continuity, this is simply 2 things to begin with. One, to empanel your patients to your provider and to the care team that supports them, so that every provider and the care team that supports that provider understands who are the patients they're responsible for, and correspondingly the patients understand who their doctor is and who the support team is for that doctor. And then secondarily, making sure that we expand the access of those patients to that provider and their care team. So expanded access can be a lot of different things. It can be opening up more hours in the evening or early mornings or weekends, but it also includes making sure that 24 hours a day, 7 days a week, 365 days a year, when that patient has a need, when your patients have a need, that they know who they can call, who they can get in touch with, and somebody who specifically can understand that patient, either because they know them because they're part of their panel, or that they're part of the larger team that has access to their electronic health record and can find out about you as a patient, what your allergies are, what your problems are, and can pass on that information after they have a time with you to the primary care team that's taking care of them. And then as we progress in this program, being able to add all sorts of innovative ways of taking care of people, that is through video visits or telephonic visits or group visits or home visits and other kinds of innovative ways to expand the access to care. And again, make it so that you only need to see those patients who really need to be seen in the office, and those patients who don't need to be seen in the office, who can be cared for on the telephone or by a group visit or some other way, care for them in that way without regard to what the costs are. We're moving again from a volume-based system to a value-based system. The second important issue in this care delivery redesign is care management. This is about the process of risk stratifying your patient population. So you really understand, based on clinical evidence and other evidence, who is the sickest in your population, and you can provide the most care for those sickest individuals. And specifically to make sure that every practice site has done that for their patient population in important ways, and then assigned care management to those patients who are the sickest, either short-term or long-term care management. And you're providing interim follow-up at those very important transitions of care when people leave the hospital or come out of the emergency department and come with new and different medication lists or follow-ups that really need to get urgent follow-up, and making sure that for each of those transitions of care that people in the care team are paying attention to those and connecting up with the patients. And then as you develop more capabilities, developing more longitudinal care plans, particularly for those high-risk patients, and focusing on advanced medication management. All those things that really help those patients who are the sickest and the most need at their most critical times of need. And then the next is comprehensiveness and coordination of care, where we make sure we can identify all those high cost and high volume specialists that we send our patients to and develop some collaboration with them so the specialist understands what we're doing in the office and you understand what the specialist is doing, and make sure there's good coordination so there's no duplication of services or effort, and there's a good communication so that everybody knows what everyone else is doing in the care continuum for those patients. It also means being able to expand the offerings that things you can do within the confines of your primary care practice. One of those important things that we ask every practice to do is to integrate behavioral health, and you'll hear more about that during the course of the day today. But that's something that's been really overlooked in primary care. One, because we've not had resources, and two, because we've not had an adequate plan to integrate those resources. But with this program, we provide both the plan and the resources to make that as easy as possible, to make sure we can both identify the behavioral health needs, those that either related to depression, anxiety, or substance use disorders, and then have resources within every practice to take care of those individuals. And then it's also making sure that we can identify the very important but often overlooked social determinants of health for your patients. That is, those things that have to do with transportation or their incomes or their ability to pay for medications, many, many other things that we know account for at least 60% of the healthcare outcomes for individuals. So we'll give you tools to both to identify those needs and also really good access to resources to help meet those needs. And that's all in comprehensiveness and coordination of care. Beneficiary and caregiver experience. This is, back to the basics, the things that we saw back with Dr. Russell and that iconic picture in Saturday Evening Post, where Dr. Russell always paid attention to listening to his patients and saying, what can I do better here in my little office to provide better care for you? We do that now with what's called a patient family advisory council, where you meet in a casual atmosphere with your patients and ask them, what can we do better? What are we not doing for you? And then respond to them. This is different than asking them when they're sitting in an exam table in a paper gown in a very compromised position and saying, how much to your doctor, how am I treating you? And you always say to your doctor, you're the best person in the world. Please just get me out of this paper gown and out of this exam room as quickly as possible. We do it in a casual atmosphere, and you get more valid answers about those things. And also making sure that we ask every patient about what their advanced care planning needs are. Something is also often overlooked in the treatment milieu. And last but not least is planned care for health outcomes, and that's doing continuous quality improvement and CQI and using all of the electronic methodologies that we have now that make healthcare both complicated in one way, but through the EHRs, but also easier to get information in and maximize the easy part and be able to minimize the excess of burden of electronic health records. So this is all about putting all those pieces together. We have a tremendous amount of resources within the program to help on both of those sides. So let's take a look at what the metrics look like for reporting, program requirements for reporting for the first year. There are two things that will be required to report on as quality measures for the first year. Those are diabetes and hypertension control. These are standard things that pretty much all practices have to report on, whether it's through their ACOs or through other federal reporting requirements. These are kind of mom and pop, apple pie kinds of standard reporting requirements to see how well you're doing with managing your patients with diabetes and hypertension. And a little different this year is the NQF 0004 screening and initiation for substance abuse. And that was included because of our very specific interest in addressing the opioid crisis across the state, which has been causing the death for more than 2,000 Marylanders every year over the last several years. And we want to make sure that our primary care practices are both paying attention to doing all the things they can do to address that opioid crisis. This year, the reporting the payment is for reporting only. It's not. It's been difficult to get all of the elements of that measure into place. So this year we've made the reporting for that simpler for you. There's also the patient satisfaction surveys, and by now practices know that there was a little bit of a heavy lift in doing the patient rosters. We're going to work together with our colleagues at the federal government to make that easier going forward. But at least we can say now that's behind you at this point. And there'll be a measure of utilization of your emergency department and hospital utilization. And you can track this along yourself on your MDPCP, CRISP portals to see how you're doing during the course of the year. All these are reported out once a year. So knowing that transformation is not an easy process, and knowing that all these pieces that we just talked about, although they sound simple in some ways, all require some elements of change at the practice level. We wanted to make sure that we weighed in as best we can to help all of the practices across the state in meeting these requirements and making these important transformational changes. One big thing that we introduced in the state are care transformation organizations. And these are organizations across the state. There are 21 of them now across the state. The practices can, on a voluntary basis, choose to partner with. And the care transformation organizations can provide care managers, pharmacists, licensed clinical social workers, community health workers, and other staffing pieces that can be difficult or challenging for small or medium-sized practices to gain on their own. They can also provide this whole list of services to support the transformational efforts. Again, it's up to the practices, and by now you would know whether your practice does or does not have a care transformation organization. More than 80% of the practices across the state in year one chose to partner with care transformation organizations. So chances are you have one already and you're working together with them. We also wanted to make sure that we provided adequate technological support to practices. So we made sure that every practice was connected up with CRISP and had all of the suites, the support suite of HIT, Health Information Technology services that CRISP provides, including the Maryland Prescription Drug Monitoring Program, the PDMP, which is mandatory anyway, but make sure that you're connected to that, but also the Encounter Notification Service, which lets you know when your patients are in the emergency room or the hospital and when they've been discharged. The Query Portal, where you can look up hospital records and other bits of information from patients being in other places outside of your facility, and Direct Secure Messaging, which allows your providers to communicate in a secure way with other providers and assure care coordination. But also we added on the MDPCP CRISP portal other features, like the quality measure reporting feature. As I said before, we have to report certain quality measures every year. Well, we've made sure that CRISP is weighing in to make that reporting as easy as possible. Also making available to you and updated on a monthly basis hospital and emergency department utilization data on specialist costs and utilization, so you can really tell who those high volume specialists that your patients are going to and create care coordination with them. Risk stratification tools. There will be in October of this year a new tool that will actually help you predict which of your patients will be likely to go to the emergency department or the hospital unnecessarily in the next month or 60 days, which will be a very powerful tool to use. Also, social determinant screening and resource directories, the ability to share care alerts and care plans across CRISP, and other features that will be developed in the future. CRISP has been a great partner in this, and hope that you're using them to the greatest extent possible. We also have a learning system, and this is part of that learning system. We have practice coaches, both the state and Care Transformation provide practice coaching. There's been a whole host of webinars, office hours, online manuals, collaborative communities through Connect, newsletters, face-to-face learning system meetings, of which the third will be occurring here in the fall, and also quarterly reporting on progress. So all of those things have been geared toward making your life easier in terms of making these transformation efforts effective. Here's a picture of some of our practice coaches. We've actually added several more. We'll continue to add those, and they're there to be called upon anytime you need them to help you with the care transformation requirements and give you, connect you up with resources of all of the kinds that were within the program. Program year one, just to recap, we had 380 practices that were accepted. There were actually 595 that applied. We couldn't take them all in for a variety of reasons in the first year. Another 150 have applied to begin in the second year, so your group will be growing to probably well over 500 practices across the state by program year two, beginning in January of 2020. The first year, there were 220,000 fee-for-service Medicare beneficiaries. We believe that that number will be well over 350,000 by the second year. 1,500 primary care providers across the state. In the first year, that number should be over 2,000. 21 care transformation organizations in the first year. And there were 3 more that have applied in the second year, so we'll have 24 care transformation organizations. As I said before, about 78% of the practices have partnered in the first year with care transformation organizations. Another 9% in a CTO-like group. So we add those together, it's 87% that are partnered with other organizations around the state to help them make these early transformation efforts. This is a picture of what you all look like across the state. The dots will be much more numerous next year, but they're also pretty numerous this year. And we anticipate also in a year or years to come, adding the federally qualified healthcare centers. So for those of you on the Eastern Shore, you know that there are quite a number of federally qualified healthcare centers dotting the Eastern Shore. So those red dots will fill in greatly once we hopefully are able to add those to the Maryland Primary Care Program. So I'll bring you back again to Dr. Russell and in this picture in Arlington, Vermont. And this is the beginning, and this is what we hope that all of your practices wind up providing the same kind of comprehensive care that Dr. Russell provided to Arlington, Vermont. We photoshopped in here one little addition, and that's a computer on the desk of Dr. Russell. And I know that's the addition that we have, but if we can bring down the costs and provide that same kind of very patient-focused, caring, and effective care that was provided in the past at the primary care level, I think we'll be making great strides. So I thank you very much for your time, and I'm looking forward to seeing how the rest of the day goes with you. Have a great day.